Good morning, good afternoon, good evening, depending on where you're joining us from. We welcome you to this week's edition of the Africa CDC media briefing. Our weekly briefing is a platform set out to facilitate our weekly engagement with members of the media, providing updates on key health issues on the continent, particularly the barrage of outbreaks that are happening with intense weather conditions. Today, our speaker with us is Dr. Ngaji Ngongo. He is the head of the Incident Management Support Team based out in the DRC. He will be sharing with us the latest on all of the outbreaks on the continent and giving us insight into actions that have been taken, giving us insight into actions that have been taken to combat these health emergencies. Just before I bring on our speaker for today, my name is Nike Wongwed. I'm sitting in for the Director of Communication, Ms. Margaret Edwin, who is our usual moderator. So just to remind you that we have language interpretation as usual on the call, so you can use the language icon on the Zoom call and pick your preferred language to listen. Let us now turn over to Dr. Ngashi for the briefing for today. Over to you, Dr. Ngashi.
Yes, thank you very much, Nikon, and a warm welcome to all the participants. I think it's always a great pleasure to have you to join for our weekly update. I would like also to start first with the apologies from the Director General, His Excellency Dr. Jean Kaseya, who couldn't make it today because of other commitment. But it's always a great pleasure on behalf of the Incident Management Support Team to give you an account of the situation where it stands right now. And today we are going to report on two diseases, on Mpox and cholera. Just to say that you've perhaps observed that we are moving more and more toward the operationalization of Plan 2.0 of the continental Mpox response that had recommended the integration of the continental emergency responses into the IMST. And cholera is the first one that we are starting with. Currently, the teams are working on the continental plan, just as we did for Mpox. And we are expecting the launch of that continental plan by His Excellency, the President of the Republic of Zambia, who is also the AU champion for cholera on the 27th of August. Now, with that, I would like to ask that you then share the PowerPoint so we can start our weekly briefing. Yes, thank you. Now, I would like first to start with just sharing some of the key interventions that we've seen driving the results that we have achieved so far. We see an overall downward trend across the continent, despite few countries, especially the new ones that are newly infected, where we see the numbers still going up. But overall, for the results that we have observed, I think on account of it, we see the leadership and the high-level engagement at member state level, that has played a very important role in, first of all, strengthening the coordination by all actors at country level, but also mobilizing the resources, including the domestic resources as we've experienced this time. And secondly is the support of WHO, Africa CDC, and all the partners working together through the incident management team that has allowed really for a lot of synergy, alignment, and harmonization of effort, in the current context of declining resources. Very important to see some efficiencies in the way that we respond. And finally, is also the great engagement of communities through community health workers and civil society organizations. I think that play an important role in really accelerating the community-based response that has been critical to improve the surveillance, but also the IPC and the home management of cases where hospital capacity has been overwhelmed. Next. Now, we also want to just share that Congo is facing double outbreaks of Mpox on one side, but also cholera. There was a visit to the Congo-Brazzaville led by the Director General himself that gave him the opportunity to meet the leadership, but also he was accompanied by a technical team that had the opportunity to also meet with the incident management team in the country and review the progress so far and identify the areas that needed most of the support. I think that mission has been extremely important and will be now the basis for all the interventions of partners in the Congo to ensure that there's integration between the two responses, but most importantly, also an intensification of the response to the cholera outbreak that has started recently. Next. Now, just giving you an overview of a public health event as of August 3rd, 2025. We have the 5 top diseases reported in 2025 this year, which include cholera. I've just spoken about Mpox, the 2 that I'm going to report today. But we also have measles that affected 18 countries. We have dengue reported in 10 countries. We have Lassa fever in 4 countries. But when we compare overall the number of high risk and moderate risk events that have been reported in 2024 for the full year, and also what has been reported in 2025 from AP week 1 to AP week 30, we have 150 events reported this year against 219 last year. As you can see that at this pace, it is clear that we are going to really go beyond the 219 to confirm the pattern that we've seen over the last 5 years, an upward trend where every year we get more events than we had the previous year. We see the same on the high-risk event, 72 reported last year. We are already at 46. And on moderate event, 147 reported last year against 104 reported in 2025. Next. Now, coming to the Mpox situation on the continent, we can see that overall, we are now around 175,000 cases that have been reported since the beginning of 2024, about 49,000 that have been confirmed, and 1,900 deaths among the suspected, giving us a case fatality rate of 1.1%, and 239 that are confirmed among the confirmed cases, giving us a case fatality rate of 0.5%. That's about half of the countries on the continent, that 27 member states that have been affected. But when you look at the situation on week 30, across the board, we see an increase in the number of suspected cases and also confirmed cases. 19% increase in suspected cases, 23% increase on confirmed cases. I think that's the overall trend. But when we also compare the data of last year and this year, we see that in 2025, we have already reported, member states have reported 94,300 cases. That represents 117 cases of the number reported last year. And also on the confirmed cases, we have 29,084 compared to 19,713. That makes 148% of cases reported in 2024. But most importantly is when we look at the dates among confirmed cases, again, we have a 421% increase in the number of deaths, moving from 45 reported last year to 194 reported in 2025. But across the board, when you look at the epi curves on the left, you'll see that both on the confirmed cases and on the suspected cases, we see a continuous decline in both. But most important also, when we compare with the epi week 19, and this week we are reporting, which is epi week 30, you see that among confirmed cases, there's a decrease of about 58%. Dare to say that what we see, it is a downward trend. But we are also happy to report that we have seen an increase in the testing coverage when we compare with week 6, no, the average of 6 week, the week 33 to week 36 of 2024, we compare with the last weeks from week 25 to week 30, we see a 57% during 57% increase during the same period. I think that is one of the bottleneck. I think that has been there reported, but we are happy to see that there's some improvement in that area. Now, that's why some of the key recommendations on the continent as we move forward is one, to really strengthen the community-led surveillance, which is important for early detection, but also push on the targeted vaccination, especially in hotspot settings of contacts, and also improve the integrated case management, given that we are in the context of comorbidities and we are seeing more of the mortality happening among people that are co-infected. Next. Now, if we start to do a deep dive into some of the most affected countries, let's start with Sierra Leone. Sierra Leone is indeed one of the best stories that we have. If you look at the peak period around week 18 and where we are now in week 30, you can see that there's really a sharp decline from 600 cases in week 19 per week to about 94 cases per week in week 30. That is really a downward trend that is also maintained when we compare week 29 and week 30. We can see that the number of suspected cases has declined by 29% from 219 to 155. We see similar decline, about 35% from 145 confirmed cases to 94 confirmed cases. And the same has also been maintained when we look at deaths among the confirmed cases, which has also moved from 7 the previous week to 4 on week 30 that is being reported. We are still dealing with clade 2B in Sierra Leone, and also very good performance on testing, 100% coverage of testing, and also 100% testing rate. And we have even seen a great improvement on the test positivity rate. If you remember, we had reported rates that were above 90%. Now, in week 30, we are now at 61%. What does that show? Is that surveillance is improving. I think we are moving toward passive surveillance, toward active surveillance, which is very good progress. That's why I think we see that in addition to that, one good thing that Sierra Leone has also done is on the vaccination side. I think they have reached 147,390 people that have been vaccinated. And we can also report that they still have about 56,000 doses of Mpox vaccine that are still in stock. I think that to say that the vaccination is moving. But very important to see who was vaccinated. 24% were health workers, 42% were contact, 11% were high-risk groups. And in terms of the age distribution, 82% of those that were vaccinated were aged between 20 and 49 years of age. Challenges remained really on the logistics and also extremely important on the resources, I think, to help the country continue on the downward trend that we have observed. Next. The situation in DRC also shows overall the same declining trend if you look at the epi curve. But when you compare week 30 with week 29, you see that there was an increase at that time, 7% increase in the number of suspected cases from 1,607 to 1,715. And same trend when it comes to confirmed cases, 109 during week 29 and 149 during week 30. Just to say that, so the interpretation of this data especially is a bit not easy because of the backlog that happens sometimes, that some of these cases were cases that were already reported, happened the weeks before, but happened to be reported during week 30. But on the deaths, I think there was 0 deaths during week 30 compared to 1 death during week 29. Now, on the clades that are circulating in the DRC, great concern. I think DRC has recently reported also clade 2B from a case of travel to West Africa. That case is in Kinshasa, which means that in Kinshasa now we have the 3 clades, 1A, 1B, and 2B. I think that calls really for a revisit of the current response strategy to also have a greater focus on the key populations that are also vulnerable to clade 1B and 2B. In terms of gender, 69% are males, and children make about 15% of all the cases that are being reported. On the testing, we still have coverage in testing coverage, which stands at 49%. The testing rate is at 72%, and the test positivity rate is at 44%. That is from 46% the week before. As you know, we always aim at having test positivity that is below 50%, because when it is higher than 50%, is a reflection of passive surveillance. That's people that fall sick and then come late in the health facilities on their own, because we want these people to be picked by the surveillance staff that are working, especially at community level. Now, in terms of the number of active cases now in the DRC is 845. And the contact listing remains a major challenge. I think for the last 6 weeks, we have a ratio of 2 contacts to 1 confirmed case, which compared with the cumulative numbers is 3 contacts to 1. That means that the contact listing is actually going down. Now, what you can see is that we try to also look at why the increase, when we've seen the country going down for about 6 weeks, 6 to 7 weeks, the numbers of confirmed cases were going down. And we understood that there are new health zones in Sankuru and Sudubangi, which are recently affected, that are now contributing to these new cases. But across the board, in all the other provinces outside these new areas, I think that downward trend has been maintained. Next. Now, in Uganda, it is the same trend. We see also an increase there, a sharp increase when you compare week 29 to week 30, both on suspected cases and confirmed cases. On suspected cases, there is a 48% increase from 146 to 216 suspected cases. On confirmed, there is a 69% increase from 74 to 125. And we also try to understand also what is contributing to this increase. And we were informed that it is because Uganda, in the search to really accelerate the response, they have intensified the active search of cases at community level, which means that now they are able to pick more cases. And we expect that as this continued in the coming weeks, we'll see now the reversal of the curve that will go back to the downward trend. Now, in addition to that, when we look at the data from week 26 to week 30, we can see even from the epi curve that there is a steady decline in the number of cases that are reported. If you look at just the confirmed cases, they have gone from 233 per week to 125 per week. That means that despite this a slight increase between week 29 and week 30 overall, we see a 46% decrease, which is really good news. But the concern remains on the high case fatality rate, as you know, also because of the co-infection that account for the high vulnerability of people living with HIV. Now, in Burundi, the same trend, also an increase between those 2 weeks, week 29 and week 30, 117% increase on the suspected cases from 84 to 182, 29% on confirmed cases from 41 to 53 during those 2 weeks. But it is still clade 1B that is circulating with males making 52% of cases and children below 15 accounting for 37. On the testing side, Burundi has maintained very good performance with testing coverage at 100% and testing rate at 100% as well. The test positivity rate has continued to go down. It was 49% in week 29 and now 29% in week 30, confirming again that the active case search is really working very well, which is even the reason why we have seen that sharp increase between week 29 and week 30. We also tried to find out from the country what was happening, and we were told that it is the activation of the community surveillance, especially in a new community that was not covered before, that allowed them to then pick cases that were actually at community that they brought into the system that accounted for that increase. We also expect that since that is around the capital city of Bujumbura that they have intensified, we hope also to see in the coming weeks again the reversal of the curve toward a declining trend. They are to say that of all the cases that have been confirmed, about 4,246, 60% of them are from 3 districts only. That is Bujumbura City, Bujumbura North, and Gitega that account for all the cases. But the capital city itself, that's Bujumbura City and Bujumbura North, account for 38% of the total. They have to confirm that it is an outbreak that has really played around the capital city more than outside the capital city. Now, also to say that Burundi controlled the Mpox through the quick response, but it was mainly the activation of community health workers that launched the active surveillance and also mobilize communities to really inform the people through risk communication and encourage people to come forward. I think that helped that decline that we have seen in the epicave of Burundi. Next slide. In Liberia, it is a different story. It is more of an outbreak that is still on the upward trend. I think when we look at the last 8 weeks, we see that that's when we had that sharp increase, which is maintained until now. But when we compare the week 29 and week 30, we see a decline on the number of suspected cases, but an increase on the number of confirmed cases. 44% on the suspected cases, that's a decrease, and 13% on the number of confirmed cases. In addition to that, what we see in Liberia, there's co-circulation of clade 2A and clade 2B, and males make 62% of cases, children 23% of all cases for the children below the age of 15. On the laboratory side, I think very good performance as well on the coverage and the testing rate that all stand at 100%. But the challenge is this fluctuating positivity rate, which has increased sharply from week 29, where it was at 35, and week 30 at 72. What does that mean is that there is still a big share of the passive surveillance, I think, that is playing, showing clearly that this is a place where active surveillance needs to be strengthened to also help not only peak cases, but also reduce the exposure of communities to the virus. The number of active cases stand at 94, and the contact listing now for the last 6 weeks is at the ratio of 1 to 11, with the cumulative at 1 to 8. Just to say, it shows that there is some positive progression on the listing of contacts happening in Liberia. Now, what we see with the epicave is that we are still on the upward trend. When we look at, from epi week 22 up to epi week 30, I think we are still going upward. But it's also important to say that of these 94 active cases, the vast majority of them are in isolation, of which 90 at home and 4 in the health facilities. As expected, I think MODERATOR account for 56% of all the cases confirmed in Liberia. Next. Now, in Mozambique, very recent outbreak that started just about 4 weeks ago. 170 suspected cases that have been reported. 29 have been confirmed. No deaths yet in Mozambique. But when we look at the performance of the lab, very good as well. The testing coverage is still at 100%. The testing rate is at 88%. The test positivity stands at 19%, and the result turnaround time at 24%. And right now, I think the number of active cases is, as we said, 27 that are currently in isolation. But the contact list is the one that is still underperforming at the ratio of 3 contacts for every confirmed case. They have to say that all these cases were concentrated in one single province, that was the province of Niassa. But recently, there's one case that has been reported in Maputo as well, making now 2 provinces that are affected in the country. But also to say that in Mozambique, I think all confirmed cases are being isolated as a strategy to interrupt transmission, which is extremely important. But when you look at these cases and also the neighboring countries to Mozambique, you see some concern about the cross-border spread to the neighboring countries. 4 of the 5 countries bordering Mozambique have all reported Mpox cases. I think that's Malawi, South Africa, Zambia, and Zimbabwe. just again emphasizing that cross-border surveillance is an area that still need our collective effort. Next. And in Guinea, also, we see a recent reactivation of cases. There's still a sharp increase when you compare week 29 with week 30. There's a sharp increase there, 468%. That's an increase from 57 cases, 8%. That's cases reported week 29 to 3. That represents about 89% increase in the number of cases. There is no death yet, and among the clade, it's clade 2A and clade 2B that are co-circulating. 70% of cases are males. Children below 15 years of age make 29% of all cases. On the testing, very good performance, 100% testing coverage, 100% testing rate. The test positivity rate for the week 30, we are reporting stands at 38%. Now, they have in total 231 active cases, and with about 1,303 contacts listed. That gives the ratio of 3 contacts for every confirmed case. Now, what we see here is cases that are concentrated in 3 regions. That is Conakry, the capital city, in Farana, and also in Kindia. And we still at the phase we see the exponential increase in the number of cases. Resources are limited. I think that's something that they have reported as one of the major constraints. Surveillance systems are still weak. The delays in case detection, and also information at community level, the level of awareness is still low. I think some of the areas that need really to be prioritized at this stage of the outbreak to help them get to bending the current trend. Next. Now, that's it on the cases. Just a quick report on the vaccination. I think so far we have 3.1 million doses that have been shipped to 12 countries that have already received them. Of those 12 countries, there are 8 that are already vaccinating. As we said, it's over 951,000 doses that have been administered. But also important to say that I think there are a few doses also plan to arrive in Sierra Leone on the 11th of August. That is just a few days from now. And also reported last time that there was a 5th round of allocation of about 249,540 doses of Mpox that were distributed to 7 countries, all those 7 countries in active transmission of Mpox. Next. There's some details on those countries. I think we have the 8 countries that are vaccinating now. Those include Nigeria, DRC, Rwanda, Central African Republic, Uganda, Sierra Leone, Liberia, and South Africa. But we just have to say that in South Africa, they have now entered the control phase, which really also brings some challenges on the vaccination, because that's if there are no cases, that means there are no contacts, and also the communication also becomes extremely important to maintain the motivation and then break the vaccine hesitancy, because there's no motivation for people to come forward and take the vaccine. There are 4 countries that do have vaccines but haven't yet started vaccinating. Those include Kenya, Cote d'Ivoire, Zambia, and Angola. 2 of those, that is Cote d'Ivoire and Angola, are also in control phase, I think with the same challenges of really not having cases around which they can mount the vaccination. And then we have Kenya that is really preparing to vaccinate. They do have cases, they're in active phase, but they're just waiting for the funds from Gavi to start. And we have also Zambia that just received the vaccines recently and should be vaccinating anytime. They had to say that from the fifth round of allocation, there are 3 new countries that were allocated the vaccines. That's Ghana, Guinea, and Malawi. I think those countries are preparing right now to fill up all the documents to be able to receive the vaccine and also organize vaccination in their countries. Next. Now, that was on Mpox. I would like to move now to the continental cholera response. On the overview, 3 main messages coming out of this slide is to show that the total number of cases of cholera on the continent is still on the upward trend. You can see that we had 104,000 cases in 22, 224,000, almost 225,000 in 23, 254,000 in 24, and now just from week 1 to week 30, we are now at 214,000. There is no doubt that at this trend, we are going to exceed the 254,000 over the year 2024. And secondly, we also see the case fatality rate that is also on the upward trend. As you know, that the recommendation from WHO is to keep the case fatality rate below 1%. But if you look at 2023, we're at 1.4, 2024, we're at 1.9, and now 2025, we are at 2.1%. That means great concern and area that needs attention. And finally, the number of member states that are affected also still on the increase, 15 in 2022, 19 in 2023, 20 in 2024, and 23 from week 1 to week 30. That means the number is still on the upward trend. Next. Now, if you can dive into the situation in the countries, let's start with Congo. What we see that Congo had an onset just a month ago. That was on July 10th when they started reporting cases. As of July 27th, about just 2 weeks and 3 days, they had already reported 335 suspected cases and 29 deaths, with a case fatality at 8.5%. I think one of the highest really on the continent. In terms of the distribution, 50% are males, and also 51% of this also among males. And persons below 20 years of age account for 35% of all cases and 35% of all deaths. But I have to say that these cases are concentrated in 2 districts. The district of Mbamu, the Mbamu Island, which is in Brazzaville, and then the district of Musaka, which is up north. But both districts, as you can see, are along the Congo River. And I think I have to say that the source of the infection is still unclear. But there are great concerns on the high case fatality rate that requires really urgency. That is one of the reasons why the Director General of Africa CDC and also with the technical team went to visit the country to see how they can support them also not on the prevention, but also on the case management to be able to lower this level of case fatality. But challenges remain. They are related to access to healthcare. There's late care seeking, especially in those affected communities. As we said, that the DG had a working session there with the leadership and also partners and identify some of the areas that were listed for immediate support to help also step up the response in Congo. Next. Yeah, this is just some of the pictures, of the visit that I've just explained. We had a multidisciplinary team that really cut across the different pillars of the response, from surveillance to IPC to case management. I think all that joined the team to ensure that in each of those areas, including even the laboratory testing, there was a thorough assessment of the priorities of intervention right now to beef up the response. Next. The situation in South Sudan is very encouraging. As you can see, that South Sudan has moved from the peak on week 18, around 3,500 cases, to where we are now reporting on week 30, 455 cases. You know, that to say this is an outbreak that is really going down. I think one of the reasons is that it is the effectiveness of the intervention that were applied in the country. When we compare week 29 with week 30, we see a 62% decline in the number of cases from 1,210 to 455. The number of deaths remained at 2, also in week 30, the same 2 that were reported in week 29. In terms of the distribution, males make 44% of cases, but 50% of deaths. And people below the age of 15, those are children below the age of 15, account for 40% of all cases. Now, some of the main highlight is the high coverage of vaccination. In South Sudan, they were able to vaccinate 94% of the target population. I think that's also one of the main contributors to the decline that we see. And the drivers of the outbreak remain the same that we see in other African countries, is the weak infrastructure or wash infrastructure. It is the insecurity, it's the population movement, it's also the shortage of supply, and also the inadequate funding that really weaken the response locally. Now, in terms of some of the main observations, I think 10.2 million doses of OCV, oral cholera vaccine, that were approved by the ICG, of which 7.7 million have already been used for vaccination in 44 countries or counties. That's why the coverage is estimated at 94%. Now, the number of cases has gone down together with the case fatality rate, I think, which is a very positive progression. If you look at just the graph there, you see the line that case fatality rate had reached 3%, you know, around week 19, but now it is down to about 1.7%. Very encouraging. And also that the strengthening of capacity continues in the area of laboratory, in the area of WASH, and also the provision of key supplies for the Emergency Operations Center. I think this is the recent supplies could amount to $320,000 in equipment that was provided to strengthen their capacity to oversee the response in South Sudan. Next. In the DRC, the numbers overall remain high, as you can see on the graph. But when you compare week 29 with week 30, we see there a 13% decline from 2,121 to 1,855. We see the same trend when we also look at case fatality, with 95% deaths reported week 29 against 87 week 30. When it comes to the distribution in terms of age, children below 15 years make 40% of all cases. But some of the main highlights also is that in the DRC, the oral cholera vaccine has also been used to vaccinate high-risk population with a coverage of 45%. And the main hotspot right now, I've been identifying the provinces of Chopo, Nord and Sud Kivu, Mai-Ndombe, Equateur, Kinshasa, Tanganyika, and Maniema. That's about 8 out of the 26 provinces of DRC where the cases are mainly concentrated. And the drivers of the outbreak include the flooding that has been reported, including even the capital city, the contamination of the water in South Kivu and also in Tanganyika. There have been cases of cross-border spread. but also the collapse of the urban water system, especially in North Kivu. Those are some of the factors that have contributed to the spread of cases in DRC. And when you look at the situation over the last 4 weeks, we can say that there's an average of 2,000 cholera cases that are reported per week, and that are translated into 293 cases per day, and also with about 13 daily deaths, I think, that are being reported. Next. The situation in Angola is also very encouraging. Just as we saw in South Sudan, it is really on the downward trend. Even when we compare week 29 to week 30, we see that the same trend is being maintained. 100 cases reported in week 30 against 102 in week 29. 4 deaths reported in week 30 against 5 in week 29. In terms of distribution, I think males make 54% of cases and 62% of deaths. Children below 15 years make 38% of cases and 32% of others. That to say, Angola has also vaccinated. They have used 1.2 million OCV doses since the beginning of the year. That's targeted 85% coverage in the outbreak zones. There to say that there are 3 provinces that are the hotspot right now. It is Luanda, KwaZulu, and Benguelo. And some of the drivers of the outbreak response in Angola, the outbreak in Angola, are the heavy rainfall, the poor wash infrastructure, and also weak access to healthcare that have driven the transmission and also the case fatality in the country. Africa CDC has been very much present in Angola. We had deployed 6 rapid response teams there to strengthen the Angola cholera response, and also trained health workers in surveillance, in IPC, in WASH, in case management, and even provided WASH supplies just to support the outbreak in Angola. But we are very happy to see this very encouraging trend, of cholera in the country, with more than 90% reduction from the peak week 18 to where we are now. If you look on the graph, you see that on week 18, the number of cases had reached 2,000 per week, but now in week 30, we are now reporting 100 cases only. You can see the tremendous progress that has been made in that country. Next. Now, in summary, I think I would say that overall, we have an Mpox that is declining across the continent, but we are concerned about the new outbreaks that have emerged in countries such as Gambia, Cameroon, and Mozambique. On the vaccination, I think very good progress, 3.1 million doses that have been delivered. Over 886,000 people that have been vaccinated, in those 8 countries that are vaccinated. But we are concerned about the co-circulation of multiple clades, especially in the DRC and also in Congo-Brazzaville, where we see clade 1, clade B, clade 2B co-circulating, with the sexual transmission of clades 1B and 2B. I think that really brings the high vulnerability, especially among a key population that need to be targeted with a greater focus. But on the cholera, we have now 23 countries that are now affected, and also the new outbreaks that were reported in Chad and Congo. But at the same time, we see some encouragement from what we see in Angola and South Sudan, where although the burden remains high, but we are seeing a declining trend. But we've reached a point whereby the IMST need to grow and integrate also cholera in its response. I think that's what we'll be working on. And both WHO, Africa CDC, and key partners like UNICEF were working together to then finalize the continental cholera outbreak response plan that is going to be launched in the next 3 weeks by His Excellency, the President of Zambia, who is also the AU champion for cholera. Why this high-level political leadership in cholera? Cholera has got one specific challenge, is that the response, more than ever, requires really the greater role of sectors outside health, such as water and sanitation, that require that leadership that is above the Ministry of Health. I think that's also the evolution where we are going with greater involvement of the political leadership in the outbreak response. I think with that, I would like to thank you for your attention, and then we are open as usual for comment and questions from the participants. Over to you, Nikhil.
Thank you, Dr. Ngashi, for a very comprehensive overview of the health emergency on the continent, focused on the multi-countries outbreaks of Mpox and cholera in the countries that were just highlighted. So colleagues, as we transition to the Q&A segment of the briefing, this section is for journalists to send questions to the speaker, and he will be providing responses. Let's note that Dr. Ngashi is also supported by other technical members of the IMST, as he has mentioned. So colleagues in the media, you know the drill of how to send in your question. Use the raise hand, as our colleagues Paul and Kemo has done. You can also send in your question to the Q&A segment on Zoom. We're going to pick that. We've had several questions already out in our chat. We'll be taking that. Just to appeal to you, Dr. Ngashi, considering the time that your briefing has taken, we will appeal for at least an additional 15 minutes to be able to have more interaction with the journalist. So let's begin with our questions, beginning with the colleagues who have raised their hand. First, we will take Kamo Chen from Minor Reporter in Sierra Leone, and then after Kamo Chen, he'll be followed by Paul Adepuchu of The Lancet. We'll do 2 questions at a time, and then Dr. Ngashi and the team will provide responses. Kamo, over to you. Kamo, can you hear us?
Hello there. Yes, I can hear you. Thank you. So I actually have 2 questions, but they are connected. They are linked. Firstly, on Sierra Leone, Dr. Ngongo, I would like you to give a little bit of make a little bit of elaboration on the ongoing surveillance, intensive surveillance that Sierra Leone has been working on. And I noticed in your presentation, you mentioned that with all the good work that has been done and the improvement we are seeing, the country needs more resources to sustain what it is attaining. I would like you to elaborate a little bit, like what kind of resources are needed. And that takes me to Guinea. And I noticed about a week or 2 ago, when we had this press conference, one of the presenters, I forgot if it is you or Prof, you compared Sierra Leone and Guinea. I mean, Guinea was in a situation where Sierra Leone was, in terms of surveillance, the cases that are coming up. But I also noticed that Guinea has slightly low test positivity rate compared to when Sierra Leone was at that point. So I want to know how this happened. What explains this? Thank you.
Thank you, Kamo. Let's take the second question. Then Dr. Ngashi and the team will respond. Paul? Paul,
yes.
Are you... Okay, go ahead.
Can you hear me?
Yes, we can hear you. Go ahead.
Yes, okay. Thank you very much for this opportunity. So the first question is broader. It's almost 3 years now that Africa CDC's revised statute granting it full autonomy was approved by the AU. I'd like to know, in addition to the power that we've seen Africa CDC exercise, which is declaring emergencies, what other concrete decision-making powers have you been able to exercise that were impossible before 2022? And I think you also mentioned integrating these IMST has been doing into the concrete plan for cholera. I'd like to know what difference would that make in addition to what is being achieved at the moment. So what difference does this new plan that you're talking about is going to bring on the table? And if I can chip in a very third one, which is looking at the role of the Africa CDC on the global scene. We've seen Africa CDC's providing technical insight in the pandemic treaty. So I'm looking at how Africa CDC has been involved in the global scene. Is there still a bigger role for the Africa CDC that it could potentially perform globally? So thank you very much.
Thank you, Paul. Dr. Ngashi, over to you and the team.
Okay, thank you very much, Kemo and Paul, for very, very interesting questions. I think let me start with Kemo on the question about
it's 5 o'clock.
Sierra Leone, the surveillance, and also the resources that are needed. I think what happened with Sierra Leone, if you remember, that Sierra Leone at the beginning, when they just launched the response, they had this community-based surveillance, which was called Find Them All. Which allowed them to go into the communities through a home visit and identify the suspected cases and bring them for testing and for confirmation. And at some point, I think they had to relax on that because of the limited resources. I think then after that, that's what also explained your second question about the high positivity rate. You remember that Sierra Leone had the positivity rate that had exceeded 90%. What does that mean? High positivity rate means that people come late at the point where they're already advanced in the disease. They come on their own. That's the passive surveillance. They come to the health facility, then they pick. Almost everyone that comes at that stage is almost sure to test positive for Mpox. But that also happened because of the collapse, the reduction in the Find Them All, the community-based response that weakened the surveillance, and then it shifted more toward passive surveillance. That's what happened. Now, what the country did then after that, they have reactivated the community-based surveillance, put more community health workers, and then expand the Find Them All to be also the same platform that not only identifies them, but also identifies the contact. If you look the way that the contact, confirmed case contact ratio has increased from about 3 to 9, it shows you that now the new community health workers are now going home to home, identifying cases, but also monitoring the contact. That's what we see. Improvement in surveillance, that you can also see even how the curve has also started going down. The positivity rate has started declining. That means that we are picking cases much earlier and then isolating them as you see the trend that they have achieved. In terms of the resources that they need resources to get the supplies, supplies on IPC supplies. They need the resources for the case management. They need the resources to pay and support community health workers. I think all those are things that for which they do need the resources. And I've been there myself. I think the IMST has already had 3 visits to Sierra Leone. I think we've been working with the country to mobilize those resources to make sure that we can reduce the gap as much as possible. The difference then between Guinea and Sierra Leone on the positivity rate is the community-based surveillance that I've just mentioned. When it is active, Guinea has started right from the beginning with a strong active surveillance. That's the reason why you see the positivity rate is low, that they are picking anyone that has got symptoms of rash and fever and so on to come into the system, of which many of them are not Mpox cases. There are also other cases that we usually see. I think that's the difference between the two countries. But the trend that we see in Guinea, because it is at the beginning of the outbreak, we see many cases, but we expect with the active surveillance and the vaccination that has also come in, and the strengthening of the IPC and the isolation and case management that we expect in the weeks to come once all those interventions are implemented, to see the declining trend. Now, on Paul, very difficult question, Paul. You are asking 3 years of full autonomy. I think Africa CDC has grown big time. When you look at, first of all, we had to declare the Mpox as a public health emergency of continental concern, as you rightly said. But secondly, the IMST, now that really puts now Africa CDC together with WHO into the leadership of the continental response. That is one of the results of giving Africa CDC more power, not only to declare, but also to lead this agenda, as you can see. And because of that, you can even see the evolution of what Africa CDC is doing. We started first by that continental coordination, so that we don't want to see multiple coordination structures anymore coming from every single organization, which bring fragmentation and waste of resources. We all bring everybody to work together as one team, with one plan, with one budget, with one M&E system. For the very first time in the history of Africa, we are experiencing that. Now, look at the evolution now, is that we had a very strong technical response, but now we are bringing it to the second level, where we see now also the involvement of our president also in emergency responses, as you see the active involvement that we have from the president of Zambia. I think those are some of the things that say that with Africa CDC having more power, we are also not only leading the coordination at continent level, but we are also mobilizing even the political leadership to be part of the public health agenda on the continent. I think we are seeing those things that are happening. In addition to that, you can see the role that Africa CDC is playing now in some of the areas that were not traditionally really accounted for Africa CDC. The head of state have also given Africa CDC the mandate to lead the health financing agenda, to lead the local manufacturing agenda. You really see that more and more Africa CDC is growing in terms of the main concerns of public health, the main drivers of public health in Africa that are now being given to Africa CDC. We can see that. Your second question is the integration of cholera. What is it going to bring? I think we have learned from Mpox one thing, that when you speak with one voice and unite your forces and your resources, you are much stronger than speaking each one separately. For example, we came up with Mpox. We had a budget of 599 million that we requested. We got pledges of 1.2 billion. That is double the amount that we wanted, because we presented the needs of the 29 countries that were affected and the needs of all the partners that were united together under the IMSC. It is that level of coordination, that level of the power of mobilizing resources through one voice that we like to use this time. Now, we need more resources for cholera. We also need to mobilize the vaccines. We need to mobilize all the supplies for case management. We need to mobilize the supplies for infection prevention and control. And also that this time we like to go even beyond the Ministry of Health to see the greater involvement of other sectors like WASH. I think it is that unity of the voice that gives us that strength to be able to mobilize more. That's what we expect, really, that integration of cholera, to also build on the experiences, some of the successes of Mpox right now, instead of duplicating again or reinventing the wheel. That's what we expect. Just gaining on the gains that we've already done. We build on the gains for us to go further with cholera. And your last question is the role of Africa CDC in global health, in general. I think, Paul, we have to say that Africa CDC has grown. If you look at the role Africa CDC played to support Gavi replenishment, everybody is talking, it's a success, it's a global success. At the time when there was all that uncertainty, Gavi was able to mobilize first 9 billion, and now I think I attended the last board that is being the amount is now being put at 10 billion right now. Look at the role that Africa CDC played. We mobilized African president, to write to the donors and make a case for vaccination as an important intervention for our children and for our population, both in time of peace and then in time of emergency. We mobilize our president to go to Brussels and support the replenishment event. You also that. That is the role that Africa CDC is playing. And right now, we are even also stepping up the level of partnership that Africa CDC has with Gavi. We are doing the same with Global Fund. We are doing the same in the pandemic agreement. You saw that Africa CDC had actually sent its expert to go and sit in Geneva to support the African negotiators, in the negotiation around the pandemic agreement. And we did the same. We're also bringing our negotiators to Addis with the ministers of health convened by Africa CDC to sit and really try to get that common voice, in the negotiation, around pandemic fund. Really, there's no single global initiative right now that happens where the voice of Africa CDC is not requested, as a genuine representative, of public health in Africa. I think that's something that is really growing. So something that you can also observe. We continue to support the pandemic fund. Right now, we are organizing with Priya an event at UNGA, on the pandemic fund, to confirm that really that role has grown, and we are almost an important partner that no one can bypass as it is now when it comes to public health on the African continent. Over to you, Nekelo.
Thank you, Dr. Ngashi. So we will go with no hands up. We'll go into the questions from the chat. I'll take a few of them from there just before we wrap up the section. So let's start off just in the context of resources. This question comes from our colleague, Emma Bata from the Writers Foundation. She asks, what impact have this year's aid cuts had on efforts to tackle neglected tropical diseases? Second question, what are the potential repercussions of aid cuts by the US and other donors? Those are two questions from our colleague, Emma. And then a second question in the set from our colleague, Justin Kaseya. He asks, does Africa CDC have an overview of how HIV programs on the continent are affected by the USG funding cuts? So I think Emma's second question and Joe's question are more related around funding. So I'll give that to you, Dr. Ngashi.
Yes, thank you very much. Thanks to Emma for those questions. One, just to say that the impact of the aid cuts on Africa is huge. We have done some work with UNICEF. I think we'll be launching that report at UNGA in September, which shows that really we have lost billions, I think more than $8 billion, I think, that have been lost to Africa. And also we looked at the programs that are most affected, as you can expect. I think HIV, malaria, immunization, I think those are some of the programs I think that are hugely affected. And you can imagine it is the same thing with neglected tropical diseases that are also affected. I think you'll see that in the report that is going to be launched. But at the same time, what you can also see is that is the new normal. At one time, we see that also as an opportunity for Africa to grow, as an opportunity for Africa to also strengthen its self-reliance. I think that's the reason why Africa CDC had to come up with this, the continental health financing strategy. that he outlined the 3+1 pillars that can help Africa, mitigate the impact of this global health financing crisis. One is that it is time for Africans to learn how to put more of their own resources into health. There's a commitment that was made in Abuja, the Abuja Declaration 20 years ago. If you look at that, out of all the 55 members in Africa, there are only 2 that managed to reach that target of 15% of their own domestic resources. We also recognize that domestic resources are not the only source, because the fiscal space of countries has got also serious constraints. What are now working is also to push for some innovative financing, looking at additional taxes that can also bring additional funding into public health on the continent. And finally, we are very much conscious that health is not only the business of the public sector. You also need the private sector to play its own role, in promoting health on the continent. That's why we have now the blended finance as another important pillar, that support, then bring also resources to invest into health in areas like, for example, the local manufacturing, the local manufacturing of communities, the digitalization of primary healthcare. I think those are areas that really the private sector can invest. They'll be also getting their own returns, but at the same time, they'll be strengthening the capacity of Africa to produce those essential commodities that can help it as part of universal health coverage on one side, and also health security. And then I said 3+1 because the fourth one is the efficiencies. We are still dealing with multiple cases of corruption, mismanagement, and so on, that we also need to minimize those. For example, some of the traits, not only what is stolen from the government coffers, it's even the way that we run business, public health on the continent. Some of the training that we were bringing people in one classroom, pay ticket and pay DSAs and so on, there are many that you can do online. I think all those are strategies of efficiency that can allow us to do a bit more with the limited resources that we are having. That's the reason why I was saying it is just an opportunity. We turn it into an opportunity for Africa to do things differently in the way that gives us more independence, more self-reliance. Now, there was another question that we were asking, how HIV programs have been affected by these cuts. As I said, HIV programs are among the very first one to be affected. But there is one reality that we are also trying to negotiate with our partners. The problem is not the cut. The problem is how the cut happened. Because cutting is okay if there is a plan over time to phase it out that allows also the member state to prepare themselves to start now chipping in progressively with domestic resources to take over. But when it is abrupt, that's why there's a problem, because it's not in one day that the government can just suddenly take over all the cost of maintaining people on antiretroviral treatment. That is where we have a problem, that on one side, we are trying to see ways that we can really bring that support to the government so that it is phased, it is not so abrupt, to allow people not to discontinue the medication, especially those on antiretrovirals, and then increase the case fatality rate, so that we can take them through. But at the same time, we started also thinking about the long-term solutions. For example, the local manufacturing of antiretrovirals on the African continent. I think that's how, Africa is not just sleeping. We are also thinking about, how do we then survive in the new era? For us, it is the new normal. We have to work on it. We have a number of solutions that are being considered now to be able to mitigate the negative impact of what has happened now with this financial cut. Over to you.
Thank you, Dr. Ngashi. Still with the issue of Mpox, I think this colleague from Sierra Leone, Kagbo from Sierra Leone Network TV, is asking, how long should a person cured from Mpox wait before having been intimate with the spouse? So the colleague wants to know, I think it's the afterlife of recovering from Mpox. I think it's the tough one there. Another question here regarding Mpox. how can we mitigate Mpox-related stigma? Any strategies done so far to address this? And then last one from Brem here, say, what are the prospects for vaccines and the vaccination of the entire African continent or population in the prevention of these vaccine-preventable diseases? So we take that one, we take one more set, and then close off for today. Over to you, Dr. Ngashi.
Okay, yeah, thank you very much. Those are very interesting questions. I think on the first one, how long should a person refrain from sex before they can come back into business? I think what we know now, it's about 8 weeks. 8 weeks. But just to say that it is one of the questions for our research pillar to also monitor the survivor and be able to also improve the knowledge and the science around the survival of the virus in an Mpox survivor. But what we know today, it is 8 weeks. Now, the second thing is how do we address the Mpox stigma? That's what we said has even become a priority as we see now the co-circulation in Central Africa of clade 1B and clade 2B. You can just see that there's more sexual transmission, and then with all the implications like the stigma that we are talking about. We don't need to reinvent the wheel. All these countries do have huge experience with the national HIV programs. I think we need then to integrate Mpox together with the HIV program, so that because they are the ones that do have already networks, with networks of people living with HIV, networks of commercial sex workers, networks of MSM on these key populations that we have, and they have many tools that they have already developed, to address the issue of stigma. We are going back to where African countries were, at the beginning of the HIV outbreak, and we have a lot to build in there. I think that's what we are recommending for all the countries. Let's leverage the experience of national HIV program to address Mpox related programs stigma because of the similarity on the mode of transmission. And then finally is the question on the prospect of vaccines. I think there are efforts that are ongoing right now, starting with, first of all, the Mpox itself. That one of the things that the IMSC has been pushing is to say that as a legacy of the Mpox response, we need to build the capacity on the African continent to be able to produce those vaccines on the continent. I think one of the things that we are discussing is the tech transfer to the African manufacturers to be able to produce that. But then one of the work that we are also doing right now at Africa CDC, we'll be producing the very first Africa Public Health Intelligence Report. In the Public Health Intelligence Report, we are identifying the diseases of Africa today and the diseases of Africa in 10 years. We are also looking at the outbreaks of Africa today and the outbreaks of Africa in 10 years. There's work that we've been doing with the European CDC, where we do the pathogen prioritization, which identify the pathogens with potential for outbreaks and pandemics. And now that's what we are linking with the local manufacturing agenda. So if we know the pathogens that are going to strike Africa today and tomorrow, how do we then also align our local manufacturing agenda to be able to produce those medical countermeasures that will allow Africa to then respond to these challenges? Medical countermeasures in terms of the diagnostics, in terms of the vaccines, and in terms of the treatment. I think that's how we see this question about the prospect of vaccines. In that context, we have the immediate one, which is Mpox, and very soon cholera. We need, first of all, to give Africa the capacity to produce those vaccines on the continent. And secondly, identify those other pathogens that might strike us tomorrow and have an agenda to produce those medical countermeasures to help the continent. Over to you.
Thank you, Dr. Ngashi. I will read two more questions, and then I will give our colleague Christopher from the German News Agency a chance to ask his question, and we're going to close with Christopher's question. So the two questions I'm going to ask, one of them says, how is the rainy season going to impact the cholera and other waterborne and insect-borne diseases in countries which are most vulnerable because of lack of wash infrastructure? And then the second question, could you please update on the performance of the active ingredients or products currently in clinical trial against Mpox, cholera, and measles? So those are the two questions that will come from us. Then Christopher, is over to you for your question, and then we're going to close with your question for today.
Right, I hope you can hear me.
Yes, we can hear you.
Lovely. Okay. Thank you very much. So almost 1 year ago, the WHO declared the Mpox outbreak to be a global health emergency. It was on the 14th of August, so next week it'll be 1 year. How did the outbreak develop in the meantime? Which challenges did you face? Which successes did you achieve? And for how long do you think this status will continue to be necessary?
Excellent questions. I think let me start with the first one. The rainy season, you remember that when I was presenting the drivers of cholera, the rainy season is one of the drivers. I think for the reason that we know, when the infrastructure is not there, then you have this rainy season that is coming, contaminated water everywhere, and people using that water for all the needs. It's a problem. Secondly, where there's open defecation, it also takes all the feces and then again contribute to exacerbating the disease. I think the rainy season is bad news, so to say. That's the reason why we are really working with countries to make sure that they are prepared to mount the response, both on the diarrheal diseases like cholera, but also on the vector-borne diseases also that are affected by the rainy season with the accumulation of water. Now, on the performance of different ingredients in clinical trials, I think we have some of them that we know already. For example, tecovirimat, which was used for the management of Mpox, clade 2B. What we did, that ingredient was tested in Africa with clade 1B. And the results showed that it was not as efficacious as it was proven with 2B. That's the reason why you've seen that in the package of interventions, tecovirimat is no more there. But you remember at the beginning, everybody was pushing that we had at least a treatment that we could give to the Mpox patient that has shown not to work. But there are others that are still being tested right now, like brencidofovir, that is being tested. I think Africa CDC is working with Panther. We don't have the response yet. I think many others that are being tested, both on the vaccines, but also on the medical countermeasures, even on the test as well. We don't have the data yet because there are ongoing clinical trials. The data is being collected. But once the analysis is done, I think we'll be more than happy to come back and report to you on their performance. Now, on Christopher's very, very, very difficult question is that, you know, last time when we had the last extension, that was in June. When we got the last extension, everybody was really hoping that we should be getting to the finish line with Mpox. But the trend in the outbreak, but also that was complicated with the insecurities and so on, all those factors at the time made it not possible to declare the end of Mpox. But if you look at it, what is good is that we have at least 17 countries that are now going downward, where we see the downward trend. Very important, as you saw, Sierra Leone is about 90% decline. from the peak. Burundi, 90% decline from the peak. 17 countries that are really going down. There's great hope there. We have about 4 countries that are, in control phase right now. There's great hope. I think our main concern is on the countries that we listed there, where we still see an upward trend. I think the country that we showed, that's where we are trying to concentrate our energy. And our hope really is to make sure that in the next 6 months, we should be able to help those countries also bend the curve. The global financial environment does not allow for prolonged outbreak of this, because it also brings the donor fatigue. Even countries do have more priority that they should be concerned about. The sooner we can bring this to close, the better. I think that's the reason why even this idea of trying to really join resources from cholera and from Mpox and also integrate all that to be able to move much faster is a strategy that we all want to help us move fast and get to closing these 2 outbreaks together.
Thank you very much, Dr. Ngaji. That answer brings us to the end of today's section. We'd like to say thanks to our colleagues for a very interactive section and participation. We look forward to seeing you next week on the same platform when we get new updates for the week from the IMST. That's Dr. Ngaji and the team there. So from our side, we're going to turn over to you now, Dr. Ngaji, for the closing. Over to you.
Yes, thank you very much. Let me just start by thanking all the participants, I think, for joining us again today for this weekly update. As we always say, you cannot realize that not only that this is the new model of emergency management on the continent, that those that are managing outbreaks really are accountable to the people. I think you represent the people. I think we feel very happy to have this opportunity to report back to you. But just also to say that you make a great contribution. I think the question that you ask, they also guide even some of our actions on the areas that we need to be also paying more attention. Christopher just asking, when do you think this thing will end? It's also a reflection that everybody would like to see this thing end. And even when we also remain behind, we reflect again to say, what can really help us end this thing as soon as possible? Just to say how much we really appreciate. The good news is that we are happy with the trend that this outbreak has taken. We are also happy with the efforts that are being made on the cholera front as well. You've seen even the countries that were high up, like Angola, like South Sudan, also going down. It really shows that all the efforts are giving us some good fruit, but we count on you to remain really engaged with us and to be also our voices, I think, with the partners that can all support this response to really help us remain engaged with you and the partners that support until we get to the finish line. Now, with that, we look forward to seeing you next week at the same time for our next update. Thank you very much, and a good goodbye to all of you.